This is the last lecture, as far as I know. And yesterday we had a very good lecture from Dr. Linus about the pathological aspect of the high-risk lesions. I will just make a refreshment of what he said, and I will show you some cases and how we manage them. So I'll start with a case, how we manage them. This was a screening mammogram of a 51-year-old woman, and there was a newly formed mass in the was detected on the right breast. This is the spot view of the mass that you see here. It's oval, here oval, circumscribed, and almost with the same density with the breast tissue. And here on the right side, you see the ultrasound image of the same lesion. It has more than 3 undulations, but it is parallel. It is well circumscribed with undulations, and it is hypoechoic. And what else? No vasculature, because it's a Doppler image. So it is a 4A lesion to be biopsied, right? There begins the problem. This is the pathological view of the lesion, that we see the ducts very well. And this was reported as fibroadenoma, and the radiologist didn't check it with the pathologist. So the main thing that you have to do at home is work with the pathologist and the surgeon. You must have a surgeon, pathological, and radiology triangle meetings. It's very important that you discuss every case, particularly the benign cases than malignant cases. Because in benign cases we have differences. We may have high-risk lesions. So this was reported as fibroadenoma and an intraductal hyperplasia, but it was a usual hyperplasia, not atypical. So they left the lesion there. It's not a very dangerous lesion, but the next year it was larger than the before. When we compared with 2013, on 2014 it was a little bit larger. And here are both ultrasound images that it still doesn't have any vessels on Doppler imaging, but it's larger and it has more than 3 undulations. So she came to me for a second opinion, and I asked for her pathological slides, and I consulted it with my pathologist, and she said that it was a very high cellular lesion other than fibroadenoma. It was not a fibroadenoma, so we preferred to excise it. And the last diagnosis was periductal stromal tumor, so it was very different than the first diagnosis. So there are some malignant and benign lesions, but in between them there is the gray zone, which is called high-risk lesions or potential lesions or borderline lesions or B3 lesions. This is not the B3 of BI-RADS. It's not BI-RADS 3, it's B3 pathology, histopathological lesions. These lesions are, as yesterday it is well explained, the atypical ductal hyperplasia, papillary lesions, radial scars or complex sclerosant lesions, the lobular neoplasias, and flat epithelial atypia. So these B3 definition is the classification of UK National Health Service breast screening program in 2001 for the reporting of diagnostic procedures without surgery. And these are uncertain malignant potential, lesions with uncertain malignant potential, with borderline histologic spectrum and variable cancer risk. And if it's a B3A, it's without atypia. If it's a B3B, it's with atypia. So atypia is one of the keys in evaluating these lesions. So these lesions starts with normal hyperplasia, then turns to atypia or DCIS or malignant lesions. That is the development of the cells in the ducts. And how are the radiological parameters of these findings? We may see a lot of different images, but particularly these lesions present themselves with calcifications, asymmetries, or distortions. And in ultrasound, ductal changes or other findings like retraction, or an MRI, most of the time they are non-mass enhancements. So if we see a mass, it's easier to evaluate, but if we see these other findings, it's not that easy. And radiopathologic correlation is very important. When you are doing the correlation, you must first ask yourself if you are well targeted the lesion. Maybe you didn't take the biopsy from the lesions itself, but surrounding tissue. Did you have enough samples, enough pieces? If it was the calcifications, did you have enough calcifications sampled? Was your samples adequate? Particularly, it's very difficult with the distortions. And the gauge of the needle is very important. For example, FNAB does not work in these cases. It should be at least 14 gauge cut needle, or a better one is the vacuum biopsy with 10 gauge or 9 gauge, whatever it is. If it's, again, the other findings and or ductal changes in ultrasound, it's very difficult to target them, so you must be sure to target them, or after the biopsy, you should place a marker there. When you need a second look, you must find where you did the biopsy exactly. And again, with the non-mass enhancements on MRI, it is very difficult to detect them in second look ultrasound. Almost 30 to 60% of these lesions can be seen on second look ultrasound. So you need an MRI-guided biopsy, but MRI-guided biopsy is not a real-time biopsy, so you may not target the real lesion. Classifications are very challenging for every radiologist, and so we have 4 different categories from BI-RADS. Heterogeneous and amorphous has medium suspicion, and linear branching and pleomorphics are more suspicious than the other 2. What are the radiological parameters? Again, the radiological pathological correlation is important, size of the lesion is important, sufficiency of the pathological specimen is important, that you must have a specimen imaging. It's mandatory. When you do the specimen, when you take a specimen, you should do the imaging of the specimen particularly if you are taking calcifications out. Number of the core biopsies are important. If it's equivocal lesion, you must at least take 4 or 5 pieces. Vacuum biopsy, if you're doing the vacuum biopsy, you must check the breast again if you have moved all the calcifications, and you must check the specimen if you have calcifications well enough taken. You may need to separate the calcified pieces from the non-calcified pieces for the pathologist. And the gauge of the needle is important, as I told you earlier. So clinical histopathological correlation must be made by the pathologist as well. Is the pathological finding is incidental, or does it correlate the targeted lesion? You must ask this for every case when you are doing a common meeting with them. Dissemination of the lesion is important. Was that focus on the one, or there were more than one foci, or was it extensive, more than 3? So this is a case that was a screening case. She was a doctor of a 45-year-old. Actually, I found this case. She had 2 different calcifications, quite separate from each other, but I thought that the one on the below was more suspicious, but she went somewhere else for the vacuum-assisted biopsy, and you see that the upper one was biopsied, but the lower one left alone there. So the result was a normal breast tissue with calcification, nothing interesting. So I have seen her 3 or 6 months later, and I told her that her biopsy was not adequate. The radiologist who did the biopsy to her did a very good biopsy. She removed every calcification here, but she missed these calcifications maybe, I don't know. Maybe she thought that it would be sufficient to just biopsy these ones. So I told her that these calcifications were quite suspicious and she needed another biopsy, but she didn't believe me, neither her surgeon. So we had an MRI. When you see the MRI, you see the segmental distribution of clumped non-mass enhancement here, which is pointing the nipple, and there is a line going to the nipple as well. So this is a ductal tree that is affected. It's like a sick lobe. When you, this was a DCIS, the final result was a DCIS. So when you have atypical hyperplasia, it's very important. It is one of the keys when you are evaluating your results, because it has 4 or 5-fold of risk, relative risk of having a cancer. Here is another calcification. It's a cluster of calcifications, some amorph, some heterogeneous maybe. And the result was atypical ductal hyperplasia. If you, in this case, if you remove all the calcifications, it's okay, because there is another foci. There isn't. It's one focus, and so you don't have to remove it. So what is atypical ductal hyperplasia? It is almost the same with DCIS. Only the difference for the pathologists is the size. When the lesion is smaller than 2 millimeters, they call it ADH, but when it's larger than, it's a DCIS. So you should be very cautious when you receive in your report an ADH result. What are the factors affecting this risk? The age of the patient, menopausal status, hormonal treatment history, family history, number of cores, enlargement pattern, size of the focus is very important, and diagnosis. If there is a diagnostic finding on mammography, it has more risk than if there is no. The contralateral cancer risk is 4-fold higher, and multifocality with family history, it is 10-fold higher. In first 10-15 years, they have the highest risk. An upgrade to core biopsy differs from one study to another. It's between 15 to 50%. But when you compare 14 gauge to 11 gauge, there is a quite difference between the upgrade to malignancy when you do the surgery, when you excise the whole area. And also the number of foci is important. If there is more than 3 foci, you see that it's the risk of having a cancer is quite high when there is only one focus. Again, same with the study. In this case, it's a small area of calcifications, but they are pleomorphic calcifications, so they are highly suspicious, and some of them were removed. This belongs to one of my colleagues. Some of them were removed, but they were not happy with the result of ADH, so it was excised, and the result was invasive ductal cancer. So you should be very cautious with your findings, particularly on mammogram. If it's a pleomorphic or linear branching calcification, finding other than ADH or a worse finding than ADH is possible. Here is another case that we had. Here you see some pleomorphic calcifications, a segmental distribution. Here you see before and after the biopsy. Most of them are removed. and you must have a specimen mammogram. There you see the calcifications are removed, but in the pathology results, they said that they haven't seen any calcifications. When you receive a report or when you talk to your pathologist and when he or she says that they didn't see any calcifications in your specimen, just show them the specimen you had, and that showed them that the calcifications were there, and maybe you may just separate the calcified tissue from the non-calcified tissue. That would help them. In this case, we didn't separate. But if they don't see it, ask them their specimen in the pathological trays and have the mammogram of it. Here you see the calcifications were on this third one, so I asked them to review this one, and they found the calcifications. So when it's an ADH or DCIS, the imaging does not differ. It's almost the same. There are two cases here. They look similar, but one of them was ADH. Even the excision was made. There was no difference. And the other one is DCIS. Another case here, you see a lot of clusters of calcification. So it is very difficult and challenging for a radiologist if you have such kind of more than one or two clusters. Which one are you going to biopsy? And so I prefer to do the more risky one. It looked like this one, but it's very difficult to biopsy them all. And so this was the most risky one. So I removed all the calcifications, and the result was even not an ADH. It was almost normal. But I had, as I told you before, I always have the MRI of these patients. And MRI showed clumped non-mass enhancement in a segmental distribution pointing the nipple here. It's like a tree here, you see. Tree and apples on a tree. It looks like apples on the tree. So it looks like a DCIS. And so there is the histopathological radiological discordance. And I told the patient, and this time I did the biopsy to two different clusters that were not as evident as this one, and we received the result of DCIS. This is another case, the calcifications. She was very anxious and she moved during the positioning, and after the positioning of the needle, you see the calcifications are below or back, behind. This is the chest wall here. So she moved. We tried 3 times. She moved every time. So at the last time, I said, I will try to use the vacuum and take out some of the calcifications. And I was able to remove some of the calcifications, but the result was only ADH. So are you comfortable with this result? No, because I know that I left a lot of calcifications. I didn't well targeted the lesion. So you should do the excision. And when we do the excision, we prefer to do the bracketing. We bracketed with 2 wires the calcification area, and it was a DCIS of moderate grade. So management of risk, we have this consensus. We had this consensus meeting in 2014, and for ADH, what we recommend is to surgical excision, particularly for the ones that are made with core needle biopsy or radiopathological discordance. But if the diagnosis is made by vacuum-assisted biopsy and you are sure that all the lesion is extracted, then you can leave. The wait and see can be justified. Here is another amorphous calcification cluster. It was an LCIS. So what is LCIS? The old definition for this is lobular hyperplasia with atypia, and the other one is lobular carcinoma in situ. But the new WHO definition is limb 1, limb 2, limb 3, with limb 3 corresponds to pleomorphic lobular neoplasia. Here, the breast cancer risk is high after 15 years, and for the ALH, it is 10-fold, but for the in situ it's 8-10-fold. So when there is an in situ, you should follow them very cautiously. You may add MRI for these patients if they are young or they have dense mammograms. Developing malignancy can be invasive ductal or invasive lobular cancer. They can both develop into different type of cancers. These studies show that it has a potential to have an upgrade after receiving hyperplasia or in situ result. But however, recent studies show that it's not as dangerous as it has been seen before. So wait and see can be one of the options. But radiopathological result correlation is again very important. Here you see a mass with spiculated borders. It is not retraction only. It looks like a mass, but I'm not sure if it's a mass or a retraction. And here on the ultrasound, you see some hypoechoic area with some shadowing, but it's not quite massy. Here on MRI, it's the same thing. You can call it a non-mass enhancement or a small mass. And this was when you receive an LCIS with this lesion, the result is not sufficient. So you should do the excision in lesions like that. Excision to whom when you receive a result like neoplasia, lobular neoplasia or in situ, if she has a breast cancer history or if she has a lobular neoplasia associating other high-risk lesions like ADH, particularly atypia is very important. LCIS, a larger ACIS, discordant imaging findings is the key, and pleomorphic variant LCIS is quite dangerous. So you can follow up the incidental finding of a focal lobular neoplasia, and if there is the radiopathological concordance. Here is another 35-year-old woman who presented with the cancer, with ductal cancer on the left breast, but she had these calcifications on the right breast. Here is the magnified view. It's a cluster of calcifications and the MRI findings, which was an atypical lobular hyperplasia. So would you excise it, or would you? If you remove all the calcifications, maybe you can stay, but she has breast cancer on the other breast, so it's very dangerous, so excision would be a good decision. Flat epithelial hyperplasia, we don't see it very frequently. When there is atypia, it has a higher risk for relative risk for being upgrading to cancer when compared to lesions without atypia. So it's not frequent. It may it does not increase breast cancer risk unless there is atypia. So follow-up is recommended if the calcification is extracted. It's the same with the consensus of EBUS in 2014. Radial scars may be painful for radiologists if they are larger. When they are larger, we call them sclerosing, complex sclerosing lesions. This is a very small lesion that you see the retraction to one point. You don't see mass in the middle. And if it's smaller than 1 centimeter, they call it radial scar. If it's larger, it's complex sclerosing lesion. They are, you may see them in 1/1000 screening mammograms. They may be multiple. Most of them are small. Here is an automated breast ultrasound finding of a patient that she didn't have any findings on mammogram. Here you see some distortion on the coronal view. Oops, sorry. There is the transverse image, and this is the transverse image finding of the handheld ultrasound. You see the distortion to a center, and there is a vessel coming through it. And here is the MRI findings. On MRI, it has a contrast enhancement. So when there is contrast enhancement and radial scar, we prefer to do a vacuum biopsy, and vacuum biopsy is enough if you have radial scar result without any atypia. This is another case. You see a distortion here, but distortion was not found on the spot view, but it was on the CC view as well. And handheld ultrasound examination by a breast radiologist was normal. But however, she had this distortion here, on the ABUS view, here and here. So we prefer to perform an MRI, and the MRI findings showed the mass with speculated borders, which then we made a second look, and we found on handheld ultrasound, and the biopsy showed that it was an invasive cancer. So these may look like each other. Radial scars may look like cancers. Cancers may look like radial scars. So be very careful, and always discuss it with your radiologist and surgeon. Another case, it's a very large lesion here, but it was a complex sclerosing lesion. So if you have this result, it's okay. So these may originate from adenosis, papilloma, or hyperplasia, or atypical ductal hyperplasia, when there is the risk is not much, when there is no atypia. So it's benign. If it's benign, there is almost no upgrade to cancer, and core biopsy of an incidental radial scar does not need an excision. And again, according to this study, you do not need to excise it if you do not see atypia. So atypia is the key word when judging these lesions. And with the atypia, you see that the relative risk is higher when there is none. So if there is atypia, you need excisional biopsy. If there are some risk factors like age or family history or self-cancer history, you may need. Radiological discordance is very important. And so without the atypia, just follow up. And the last lesion is papillomas. Papillomas we see quite much. They may show in mammogram like masses or calcifications. They may be peripheral or central. When they are peripheral, they have more risk to have malignancy. When there is atypia, when compared to without atypia, the relative risk is higher. Here is a lesion here you see on mammogram and MRI. It's more than one, it's multiple. So you may ask them to be removed because they are not central. It looks like it's a little bit peripheral. It goes deep here. The contrast enhancement goes very deep. Another case, again, here you see a lot of, a linear contrast enhancement here. It looks like multiple papillomas and peripheral localization. This is the ultrasound finding of the patient. So there may be different epithelial changes in a papilloma. If it is multiple, the risk is higher. If there is atypia, the risk is higher. So the keywords here are multiple to be multiple and has an atypia in the papilloma. What are the challenges for the pathologist when you do the, particularly with the TrueCut biopsy, they receive small fragmented specimens. It's very hard for them to evaluate. And the papillary lesions are heterogeneous, so be very careful. They are complex lesions. You may just target the normal part of the papilloma, but there may be harboring a malignant part in somewhere else that you didn't target. So be very cautious in judging these lesions. When there is radiology pathology correlation, the upgrade to malignancy is very low. So you don't need to excise them if there is no atypia, if they are not multiple, if they are not peripheral. This is a case where you see contrast enhancement here. It looks like a mass, and here it looks like a distortion. On automated breast ultrasound, you see two lesions close to each other, one on the 3 o'clock and one on 2 o'clock or 2:30. Here the transverse image of the lesion on the upper part, and here on the lower part. It looks like mass. It has a continuity with the ductal system, so it looks like papilloma. Here are the handheld findings. You see you see the ducts going out of it very well, particularly in this one on the lower side. It's continuing with the ductal system. So the result was papilloma with the atypia. You have to remove it. We removed it, but it didn't harbor any cancer. So surgical the excision is needed for lesions, particularly with atypia, and for the ones that are peripheral and multiple. But there is still not consensus between the pathologists or radiologists. You see these answers for different lesions from different disciplinaries here, and you don't see any consensus. Still, there is not consensus much. This is a study with breast surgeons from 477 physicians, and you see still there is no consensus for the excision or selective excision or follow-up of the patients. But however, cancer risk in B3 lesions it is 17% according to this study. It may upgrade to malignancy when you take them all together. It is more with the ones with the atypia. And this study also, it's a survey for the lesions detected on core needle biopsy at American academic institutions. Here you have the answers. It's very small. Yes, for the ADH, almost there is consensus for excision, but it's not for AALH, sorry. Again, for papilloma, different answers. So another consensus is for papilloma with atypia. Is there a role for MRI for these B3 lesions? Yes, particularly for non-mass enhancements, there is a percentage of 43% malignancy risk in these cases, particularly if they are enhancing with contrast. And the negative predictive value is quite high for papilloma and radial scar, but a little bit lower for ADH and lobular neoplasia. Here, when you look at the overall results, contrast-enhancing lesions are more dangerous than the non-contrast-enhancing lesions. So if it's a contrast-enhancing lesion, you should be more cautious when evaluating the result of your biopsy. So what do we do? If it's a category 4A lesion and there is a correlation and there is no atypia, you can stop. But if it's a category B, 4B or 4C lesion, you must be cautious, re-evaluate very well. if it's a 4C lesion, if it looks like malignant on the imaging, you should re-biopsy. And sufficiency of the specimen is very important. Check for the sufficiency, number of the specimens, bore of the needle, and targeting. Just go and revise your biopsy. Lesion size is important. In small lesions, you may miss the target. Radiology pathological correlation should be made in a common meeting, and you must also keep an eye on risk factors of the patient. Another take-home messages: under imaging guidance, the adequate biopsy is the key, so be sure that your biopsy is adequate by doing the specimen radiogram and also re-imaging of the breast after biopsy. If there is any doubt, check every step of your biopsy. Atypia is one of the important variables for excisional biopsy, and MRI can help for decision making, image correlation with your mammogram findings and ultrasound findings. Particularly contrast enhancing non-mass enhancements are important in the evaluation, in the decision-making process. Surgeon, radiologist, pathologist meetings are fundamental. You must do them every week. If you can't do it every 15 days, every 2 weeks at least. Thank you very much. Any questions? Everyone is tired.